Good afternoon. I'm Dr. Silvia Priori, Professor of Cardiology at the University of Pavia. The prevention of sudden cardiac death still remains a big challenge in today's medicine. One of the reasons why it is still difficult to predict the individuals at higher risk of sudden cardiac death is probably related to a stochastic or probabilistic substrate of sudden cardiac death, whereby individuals may have a substrate that destabilizes the electrical rhythm of the heart, but it only when there are some precipitating factors spanning from electrolytes abnormality, activity, exercise, increased oxygen consumption, and so on, that the arrhythmia actually develop. So the field has been developing and trying to identify markers for increased arrhythmic risk. Basically, we could divide the topic of sudden cardiac death in two groups. Sudden cardiac death occurring after age 40, that is predominantly a consequence of ischemic heart disease, and sudden cardiac death in the younger population, where inherited forms prevail, despite a certain percentage is still caused by coronary artery abnormalities. If we look at the patients with ischemic heart disease above the age of 35, and 40, what we see is that the ejection fraction remains the main indicator for risk of sudden cardiac death. It is therefore, especially when the time comes that the ventricular dysfunction is altered, that the patients start having an increased risk of sudden cardiac death. Trials have demonstrated that the implant of a defibrillator is recommended in individuals with a myocardial infarction when ejection fraction is below 35%, especially when New York Heart class is between class 2 and class 3. We have much more complexity in defining the risk stratifier when we look at the patients that are younger and have a variety of genetic diseases spanning from cardiomyopathies and channelopathies. There, what we identify as a risk, unfortunately, is primarily the fact of having survived a previous cardiac arrest. That, of course, is not sufficient. A lot of hope has recently been posed toward the use of genetic testing that has helped in some diseases like long QT syndrome of hypertrophic cardiomyopathy to spot the individual at higher risk of sudden cardiac death, and therefore there we should focus our attention in identifying when an ICD is needed. Now, if we want to implement programs to identify early patients that have an increased risk of sudden death, two different approaches have been proposed. On one side, the classical population screening. On the other side, the newest use of genetic screening of the population. Where do we stand with that? Screening of the population has been debated because even if it's simple electrocardiogram as a low cost, it is often the cost of secondary examination prompted by an uncertain interpretation of the electrocardiogram that has actually a role of increasing the cost. A recent study from the UK presented at the last European Heart Society meeting has demonstrated that the experience of the readers is the major determinant of the cost, because experienced and specifically trained people, doctors who can run a screening program, spend much less and make the screening program tolerable and not over excessively costing. So I think that these data are designing a new way in how the screening program, especially in which hands we should put the screening program. To conclude, the genetic testing in the population, that is definitely not yet something that is appealing and something that can be done. It's still too costly, too difficult to interpret, and therefore we will have to wait the future ability of interpret the results that is coming from large databases of the normal population that will allow us to have, hopefully, a greater understanding of the meaning of these genetic results, so that people could be screened maybe at birth and their risk be identified right there, especially for the risk of developing ischemic heart disease and the risk of having arrhythmias genetically or with genetic origin. Thank you.